pounding, pulsing, sometimes debilitating pain. On today's All Things Brain Health, we look at what treatments bring relief and how to get ahead to prevent your next migraine. Good morning, I'm Alexis Del Cid. Welcome to All Things Brain Health. Migraines can come out of nowhere. It's a headache that can cause intense throbbing pain or a pulsing feeling, usually on one side of your head. Oftentimes it happens with nausea, vomiting, or sensitivity to light and sound. And most of us probably have a loved one who deals with them, or maybe you're the one who suffers from migraines. The World Health Organization says migraines are one of the most top 10 disabling medical illnesses in the world. But what's happening inside your brain to cause them? And more importantly, how can we stop them? That's what we're exploring today. And we have a great panel for you. Please welcome Dr. Deetra Ford. We are so happy to have Dr. Ford here, the Chief of General Neurology and Director of Outpatient Neurology Services here at the University of Kansas Health System. And we have Victoria Draffin. Victoria is a nurse practitioner who works very closely with Dr. Deetra Ford. We also have two of Dr. Ford's patients joining us this morning. We have Jennifer Jackson joining us, and we have Dr. Jennifer Diltz. Dr. Diltz happens to be a pediatrician who is board certified in headache medicine. Quite a cast this morning. Thank you for making time for being here. I want to start with our migraine sufferers, Dr. Diltz and Jennifer. Jennifer, I'll start with you. When was the most recent really bad migraine you had?
Just this weekend was a really bad one. When I get my migraines, I can tell they're coming. It's kind of almost, I want to say it's almost like an anxious feeling you get. It's like and then
like a panic attack coming on?
Kind of a little bit.
Okay.
And then you get the aura, and it starts as this tiny little thing. And that aura is one little dot in your eye that, I say it looks like a crescent-shaped moon, but it's like a lightning bolt. That's a crescent-shaped moon, and it starts small, and it goes big, 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 and it'll take over your entire vision. And
so it's just, is it just white?
It's clear. It's like looking through water almost. And when you get that, when you even start to see the beginning of that dot, that's when you have to take your medicine at that point in time, and then you know you're a couple hours down, you're going to be laying down, quiet room, no light, and the family all knows when I get those, that's when it's time for me to just kind of shut down.
And are you in excruciating pain on one side of your head?
Yes, always. Now, fortunately, with Dr. Ford, the medications she's given me have made it so it's not as horrible as it used to be. And like I said, biggest thing for me is prevention. So, but when I do get them, we can try to medicate it as best as possible, but it's just not,
for a few hours.
Could be a day.
Oh gosh.
Yeah.
Oh man. And Dr. Diltz, what was the worst migraine you've ever had? How long did it last?
The worst one I ever had lasted a couple of days. Thankfully, but thankfully I've gotten pretty good, and working with Dr. Ford too has helped at recognizing when a migraine attack starts, and usually I can treat it quickly so that within a couple of hours I'm feeling better.
When you had it lasting a couple of days, were you practicing medicine at that time? Did you have to miss work?
I was, yes. I did miss work for that.
You treat the littlest of headache patients as well.
Yes.
Is that what inspired you to become a headache specialist for children?
It is, yes. I get migraines. My husband and all three of my daughters get migraine, and so I feel really passionately about explaining pain to kids and their parents, and there's not enough of us doing this work. You all know that, and so I really enjoy doing this work.
Well, it's probably so helpful to those patients and the parents who
I think so.
Who feel understood.
Right.
Dr. Ford, what is happening inside the brain during a migraine that's different from a typical headache?
Yeah, so I like to think of it as a storm. So things just start firing and misfiring. It becomes more and more chaotic in there. And those chaotic signals release chemicals and inflammatory mediators that then lead to activation of our pain centers and our sensitization there, and leads to the debilitating pain as well as other side effects that come along with a migraine, like the nausea, vomiting, light and sound sensitivity.
Man, and Victoria, is in your experience as being a nurse practitioner treating patients with migraines, how long do they typically last?
Typically at least 4 hours.
Okay, and would 2 to 3 days, like Dr. Diltz had, would that be an extreme case, or is that something that other patients do have?
Yeah, we do see it with our other patients as well.
When they finally come to you, are they so sad because they feel hopeless?
Yeah, a lot of the times by the time they get to neurology, they've started with their primary cares or they've been sufferers for many of years. And so by the time they get to us, they're really desperate for treatment and answers. And sometimes it's a step process to get them of trial and error, because not every medication works for every patient.
Right. Jennifer, how old were you when you first started getting migraines?
Well, I love to hear that Dr. Diltz is working with children, because the earliest one I remember, I had to be 12, 13. And I remember telling my mom that my brain felt like it was on fire.
Oh, wow.
And then it sort of, it went away. It really kicked in my early to mid-20s. That's when I started getting them significantly.
But you remember when you were 12?
I remember 12 or 13 saying my brain was on fire.
What did your mom say?
She gave me a couple aspirins,
right.
And you know, that was the best we could do. But my father had also suffered from migraines.
Okay.
So he would just lay with a wet towel on his head, and you know, genetic. Yeah, my brother gets them.
So it is genetic?
Absolutely can be. There's definitely a component for that.
When you would get those migraines, what was the biggest impact it had on you trying to function in your 20s?
Sure.
And then how long did it take you to finally get diagnosed and get in with
Sure.
Dr. Ford?
So it's hard to say how it affected my life, because basically there are times when you just have to keep going. And I was a single mom for 18 years, so being able to take that off was not an option for me.
Right.
So we take the medicine and rest when I can, and do the best we can at just...
Who's in those pictures?
Oh, that's my husband and me. Yeah, we travel a lot.
I love that. Okay,
Yeah,
I wanted to explain to our audience what we were looking at.
Oh, and there's my bestie and me. We love to travel a lot, and we love to just take on the world. That picture right there is in France, in Marseille, and big baseball fans. So we don't like to be interrupted by what I've got going on. And so, so I was taking just some basic medications back in the 2000s, things that, you know, Migraine, and things that were basically Tylenol, maybe a little more intense than Tylenol.
Is Migraine over the counter? Is that?
Well,
Not really there anymore.
no, it's something.
Okay,
This was from a long time ago.
Okay.
But no, but now, before I saw Dr. Ford, I was getting probably 15 to 17 a week.
Oh, gosh.
And it could be just the flashes like you were talking about,
Right.
or it could be the full-on migraine. And now I get maybe one a week.
Dr. Diltz, what was your experience growing up? Did you grow up with migraines as well? And then how long did it take you to get help?
I actually didn't. I was in my early 30s before I started getting migraines, and even as a pediatrician, I wasn't a headache physician at the time, but even as a pediatrician, I didn't initially realize that it was migraines that I was having, because I had a lot of neck pain and then a lot of nausea with them, but at least initially not a lot of that throbbing pain, and so it took me a little while to realize that that's what it was.
I wouldn't associate neck pain or nausea with a migraine.
Yeah.
Did that take you a long time then to get diagnosed as, okay, these are migraines?
It did. I actually had already started my migraine training, and I was like, wait a minute, this is what I'm dealing with. And so it was really interesting the way that happened.
Victoria and Dr. Ford are both vigorously nodding their heads to the neck pain and the nausea. How common is that, and what symptoms do you typically see patients come in with?
So neck pain's actually, they did a study on this because they do a study on everything. So neck pain's actually one of the absolute highest leading signs that you're going to get a migraine.
Is it possible you could be having neck pain and nausea and never have a headache, but that's a migraine?
It is possible. There are typically some other symptoms with that. The old term was acephalgic migraine, so basically a migraine without the pain. So you can get
acephalgic?
The aura.
Okay.
So you can get the aura, you can get the other side effects with it, the nausea, the vomiting, the light and sound sensitivity, feeling just terribly hungover and not actually get the pain.
And Victoria, what do your patients tell you about that?
Yeah, so generally they have a lot of upper back, neck tension that they say will start in the base of the skull, wraps around, and then that's when they can start to experience some of the other symptoms.
Why do we get nauseated? Why do people get nauseated with migraines?
That's a great question. We have a lot of theories on that. Some of the thought is that you do get some slowing down of your GI tract, a little gastroparesis, slowing of everything. Also, though, part of where these migraine symptoms can hit are sometimes in the centers that can cause nausea in our brain as well. So a couple of reasons why, and then just pain.
Pain all over the place.
Absolutely.
When it comes to medications, there's something called the CGRP inhibitors, which are showing promise in treating migraines. As someone who hasn't suffered from them, CGRP, how would you explain what a CGRP inhibitor is?
Great. So make it pretty simple. They're these little molecules that get released during a migraine or at the very beginning, and these new medications help block those molecules or the receptors where they bind, and so by default that then reduces the pain that comes along with them. And for the folks who take them as prevention, it over long periods of time kind of downregulates those processes so that you have fewer migraines, less pain, less breakthrough.
And Victoria, is that a first-line medication that you would prescribe?
Absolutely.
So that's the first, is that a relatively new medication, and how new is it?
It is relatively new. I would say for insurance purposes, we do have to do a trial of other medications, unfortunately, before we can get to those. Would you say within the last 5 years? Yeah.
5 years. So when, Jennifer, you're talking about how you would take Midroll that isn't offered anymore, at what point, and did you start taking CGRP inhibitors, and at what point?
I don't know, do I?
She's been on a combination of a lot of things.
I've got a shot that I take called Emgality.
It's a shot that is administered to you?
Yeah, my husband gives it to me once a month, and I take magnesium, and I take folic acid and vitamin B. And
those are all over the counter.
Those are over the counter, so that's part of my daily routine. And the medication I take when I do get a breakthrough, it's called Nurtec, and I just take
CGRP?
Yeah, it works on that same molecule. It's a small molecule drug, which is an acute prevention as well. They have both prevention or acute with that medicine.
Yeah, and the Nurtec is the one that I take once I start feeling that, and boy, I didn't know the neck pain, but that's absolutely a trigger for me, or not a trigger, but that's a warning sign that it's coming. That's when I take the Nurtec, and it's time to go lay down and just not do anything.
Yeah, say bye. But I can't imagine how you did that with being a single mom of how many kids?
I had 2 kids.
Single mom of 2 little kids running around. You can't really say night-night.
No, you can't. You can't. But they knew when mommy had a really bad headache, they knew that it was time to take out their coloring books or things like that. They understood that while they're grown adults now, and my daughter's a physician as well. And so,
is she a physician here?
She's a physician at Children's Mercy.
Okay, we love Children's Mercy.
Yeah, yeah.
So Dr. Diltz, what was your experience like with finally finding treatment? What worked for you?
Botox injections are what has been the most effective for me, for sure. Yeah.
I've seen someone getting Botox all over her head.
Yeah.
For that, do you get the Botox in a doctor's office?
Yeah, with Dr. Ford.
Do you administer the Botox?
Yes.
I do, and so does Victoria.
Yes.
After you get Botox in your head, does your whole head feel frozen too? Like people describe?
Mine doesn't, no.
Okay.
It's a little bit
You get it
sore
too?
afterwards,
Yes.
but not bad.
You look fantastic. Not a wrinkle.
Oh, thanks.
Wow. So how long does the Botox treatment last?
It lasts about 12 weeks, and so about every 3 months I get it again.
And then how long does it take to administer the Botox? Victoria, you do it too?
I do. We do it relatively quick. I mean, we book them in a 15, 20-minute procedure slot.
How many shots, though, are in?
It's 31 injections.
Wow.
There's a lot.
But that's what's working.
Yes.
Thank goodness.
Yes.
Holy smokes. We know that the FDA also recently approved prescribing CGRP medications for children ages 6 to 17. Dr. Dilts, when do you decide to take that approach for your little patients?
So that really has been life-changing for a lot of my teen patients. That class of medications just got approved this past August for kids down to age 6. Before that, it was ages 18 and up. And so I am using CGRP inhibitors in a lot of my teen patients, and it's great. They do the shot once a month at home, so they don't have to remember to take a daily medication. And there are a lot fewer side effects than a lot of the other medicines that we use. So I use it a lot, especially in my teen patients.
Would you ever administer Botox to your teen patients or your child patients?
Yeah, so we do some. It's off-label for under 18, and so it's not something that we do super often in our teen patients, but we do it some, yeah.
What is it about the Botox that works on preventing migraines?
So there are a couple different ways we think it works. So definitely some direct muscle relaxation, obviously, because you're injecting into some of these larger muscle groups that it will help with. Also, though, it hits the nociceptive pain receptors, and it actually has downstream activity on calcium channels and CGRP as well.
So there are pain receptors in the head that you can kind of calm down and deactivate?
To a degree, yes.
That's super interesting. Dr. Dilts, you've talked about your personal experience shaping the way you speak to your young patients. Have you ever, what's the littlest patient you've had come into you, and how do you have that conversation?
Yeah, so I've seen patients as young as age 3. Migraine can start really young, especially when there's a family history of it. And so I use the storm analogy a lot of times too, and we really focus on, just like you were saying, prevention, kind of noticing those symptoms as soon as they're starting. And with the younger kids, a lot of times it's how they behave. They may not tell you that their belly hurts or that they're light or sound sensitive, but they just want to go lay down in a dark, quiet room, or I've had kids that lie in their closets when they're having a migraine. And so thankfully it's really hopeful right now. We have so many good treatments, and so the sooner that we can see kids and teens with migraine, the better the treatments work and the faster that we can get them back to doing everything that they want to do.
You were saying you were practicing medicine, but you realized there weren't enough migraine specialists for children.
Yeah.
How bad is that shortage? Would you call it a shortage?
Absolutely, it's a shortage, yes. I don't know how many there are in the states of Kansas and Missouri, but very few, and people wait a long time to get in to see headache specialists, both in the adult world and also in the peds world too.
And we're super lucky here at the health system to have some top-notch specialists. We have Dr. Ford here, and we have Victoria. Do you find people finally reaching you and saying, thank God, I thought I'd never find anyone?
Our wait is pretty long, so yes, it is difficult. And it's also interesting to me how many people have not had treatment yet, who've actually tried no medications, they've never been on an appropriate migraine regimen, and they've had migraines for 20 years. And so that's always fascinating to me, and I'm sure that happens in the peds world too, because you know, as parents, I'm a mom too, we try to treat at home as long as we can, but really seeking out those specialists is very, very important.
Let's talk a little bit more about auras. Would the type of aura someone is experiencing affect the kind of migraine that's coming, Victoria?
So it can. I think for adults, we usually see a lot more visual auras, where I'm sure with your pediatrics, you see a little bit more abdominal and GI symptoms. And so when we see those auras is when we want to recommend patients to do their fast-acting or abortive treatment.
So an aura can also be a stomach ache or a neck ache? So any precursor is an aura?
There are different kinds that actually qualify for aura. So there's up to 2 days before a migraine, you can have kind of this prodrome of symptoms. You can get increased urination, increased yawning, increase in neck pain, all of those things, kind of irritability. Those are some of the most common, and then it starts to progress at that point to oftentimes visual auras being the most common, but you can get sensory auras where you get numbness and tingling in the distribution, and then the most concerning can be weakness. So you can actually have what looks like a stroke, so a motor aura. So those are a little bit more difficult to treat. Victoria can comment on that, but we have to be a little more careful with those.
And that's what, Victoria, can you talk a little bit about how you treat based on the aura?
Absolutely. So there is the drug class called triptan, which is a vasoconstrictor. So with our patients that do have those motor auras where they're going to have the weakness, we try to avoid that drug class because it's going to increase the risk for adverse vascular outcomes. So that's where we would like to utilize the newer CGRP abortive medications.
I heard Jennifer call you her potion queen. What did you?
Master.
Potion master.
Yeah, it's an old Harry Potter thing.
Yeah, we are Harry Potter.
Yeah, she is my potion master because she has gotten me to the point where it's not just my main thing now is treating them when I get them. Because otherwise, we're doing such a great job at preventing them that I remember one week I came in and I was talking with one of your nurses, and I told her, I said, it's been 7 days. And she's like, Jen, that's not good. I said, no, really, that's good.
That was good for you.
That's really good.
We have some really good questions and comments coming in, so if you have a question or a comment that you'd like us to read out loud on the program, you can send that to us right now on YouTube or Facebook. Those links on how to connect with us in real time are right there on your screen. Dr. Ford, when it comes to triggers, in your years as a neurologist, what are the most common triggers that you see?
So by far, stress is a huge one. Sleep changes is big, so too much or too little. So I typically ask for people to have a similar bedtime and wake time every day, even on the weekends, even if you're in college, whatever it may be.
How does that go over with your college patients?
Sometimes that's a tough conversation.
I can't see that happening.
No, sometimes that one's tough. Sometimes it's caffeine or other dietary triggers. Weather
Those are the
is very
triggers. Okay.
Sometimes. And weather's a really big one as well.
I was surprised to hear you say caffeine because, Victoria, I just heard Jennifer say before the show that caffeine helps her. If she doesn't have caffeine, she gets a migraine.
Absolutely. So it can be tricky because you want to be consistent with that caffeine intake. And so too much or too little can be a trigger. So let's say you're used to having 1 cup of coffee every morning. Well, if you get a migraine, some patients find adding an extra cup of coffee can also help.
Okay. And Dr. Dilts, what are your triggers?
Stress is a big one.
Yes.
Weather changes, lack of sleep. Those are my big ones.
You're a doctor living in the Midwest. You have stress and plenty of weather changes.
Yes.
Have you been having a rough time this fall with all our up and down temperatures?
It's been a little hit or miss. There have been a few weeks that have been worse than others. Yeah.
And what are your most common triggers?
The weather.
The weather, okay.
Yeah, spring is definitely, severe weather season. And I've seen some meteorologists who have given weather or what are they calling them?
Migraine reports?
Migraine reports, yes. And honestly, I'll pre-treat if I see something that the barometric pressure is going to go up and down and up and down. That's a big one. And of course, stress.
What does pre-treating look like?
Pre-treating is taking a Nurtec. That it's one of my medicines that Dr. Ford has prescribed for me. And I'll just take that and I can't say whether it's what prevented the migraine, but what I can say is I didn't get one. So,
Dr. Dilts, have you ever had a migraine come on, and if so, what was it like while you're working and treating patients?
Thankfully, anymore, most of mine aren't so severe that I can't still function with them.
Right.
So many of us in the migraine community are still working and functioning even with our migraines, and sometimes it's hard for other people to tell.
And we have video of you working too, and treating patients and everything.
Yeah.
And while we roll that, I want to get to some of our community questions. Jeremy Yenser wants to know, why do some migraines with that eye aura not cause any pain? Have you ever had a migraine, Dr. Dilts, with an eye aura that doesn't cause pain?
As far as in one of my patients?
Yeah, or with you.
So I don't actually get aura. I get some of those warning signals like the neck pain, but I don't myself get aura. But sometimes there can be auras without getting the head pain.
And
I have had auras that, again, maybe it's the medicine. Okay, but I've had auras where I'm like, okay, is it gonna hurt? Is it gonna hurt? Is it gonna hurt? And it doesn't hurt.
Huh? Why would that be?
So for Jennifer, the case is that she usually takes her medication for acute, and it stops that response. It stops that kind of that storm that's starting. It's stopping that. So I look at the aura as kind of a ripple effect on a pond. It's that first little wind that goes across the pond that says something's coming, and so she's stopping it before all those other inflammatory mediators can release and cause the pain for her.
Jeremy Yenser has a comment. He says, the lightning storm in the brain makes me think of epilepsy. Are there any relations between epilepsy, what triggers a migraine? Are they in the same neighborhood? Is there a connection?
That's a great question. So I went to a fabulous lecture one time from a famous epileptologist who actually said they felt migraines and epilepsy did share a lot of the same common features. There's definitely differences, obviously, with a lot of motor activation, typically with the epilepsy or seizures. But if you think about triggers, a lot of them are the same. Severe stress, lack of sleep, changes in diet, alcohol. So a lot of the triggers are going to be very similar. So we have the same conversations. It's just, I think the outcome of that electrical storm is different, and kind of the mediators of what drives it are different.
Do you, we actually just a couple weeks ago had on Veterans Day, a veteran who developed post-traumatic epilepsy. What reminded me of that was when Jennifer said she feels anxiety as a precursor, and he would feel some sort of, his aura or precursor was a really anxious feeling, like something's about to happen. How does that description sit with you, with your patients?
Absolutely, we can definitely see that for them, that they can say, I don't know why I feel anxious. I have no reason to feel anxious, and then their migraine symptoms can start.
Do you have patients who have epilepsy and also migraines? Is there so they get the double whammy?
Absolutely.
Boy, that's rough. I have a comment from, Jean Reardon. I'll get to a comment in a second. Jean wants to know, are women more likely to have migraines than men? Yes. We do have an all-female panel here today.
Yeah, it's about 3 to 1. Actually.
3 to 1.
Yeah, much
oh
more
boy.
In females, and there are lots of thoughts on why that is. Hormones probably play a big role in that. So yeah, absolutely.
Marie has a comment. She writes, I remember 40 years ago, one of my childhood best friends missed an entire 4 months of school because of her migraines. Does that still happen to some children? And does new research, is it helping avoid that? Does it still happen now? Gosh, that's a... Do you have children missing, or children missing 4 months of school sometimes?
Yes,
yes,
I do sometimes, and usually it's that they don't know that there are good treatments out there, and so it takes several months before they see a headache specialist like myself. And it always breaks my heart when we see that, because again, there are so many good treatments, and we want to see kids as early as we can so that we can prevent that.
So having the developments we have now and all the different tools in your toolbox that Victoria and Dr. Ford and Dr. Dilts use, should that be still happening now? And should any child be missing 4 months of school? Or can that be totally avoided?
I mean, I don't see kids, but I can say that it is not always totally avoidable. So I look at migraine like any other disease state, because it really is. And so you can have different levels of migraine. You have episodic that happen a few times and are treatable with your acute therapies, and then you have more of a chronic migraine that's greater than 15 days a month that requires more intense therapies. And then unfortunately we do have some people that I would say are chronic intractable migraine, that have a migraine every single day of their life. And
chronic intractable.
Terrible. Yes. And so absolutely could miss multiple days, for sure.
Alice has a question about therapies being studied. She wants to know, are there any therapies or medications currently being studied or on the edge of being implemented?
Yeah, there's a new class that's being studied right now. We're shortening the name to PCAP, but works on a different receptor than anything we've had before, and hopefully has a very low side effect profile from the beginning studies that we've seen so far. So we're really looking forward to that in the near future.
Tom wants to know if surgery is ever an option to treat migraines.
I can take that one too. So there is a lot of evidence out there that's conflicting depending on which body of evidence you look at. The overall American Academy of Neurology says right now that there's not enough evidence to do anything with surgical implementation of actually cutting nerves or muscles. That being said, for occipital neuralgia, so a different kind of pain, we have seen some success with occipital nerve stimulators, and we do that here at the University of Kansas.
Marge has a question for Dr. Dilts. She wants to know if you and Dr. Ford knew each other ahead of time.
You know, we didn't. I knew of Dr. Ford, and I knew she was amazing, and I had, you know, because migraine is genetic, a lot of times my patients' parents are seeing neurologists and headache physicians for their own migraine. So I had a lot of parents that saw Dr. Ford, and I was recommending her to my patients' parents, and when my patients age out of seeing me, so I was recommending her a lot of the time. time before I actually got to know her myself.
And so it made sense to hit her
Right.
up as your doctor.
Absolutely.
And it's been quite helpful to both of you. Thank you so much for joining this conversation. For today's takeaways, I want to start with Jennifer. Jennifer, what do you want people watching to know who have a loved one that suffers from migraines?
Migraine is not just a headache. I have heard people say, "Oh, I've got a migraine. I've got a headache." There's a very big difference, and if someone is having more than just pain in their head, then and if it's just in the one side, like we've talked about, please, you've got people like Dr. Ford who are wonderful. I work for the health system too, and I know we have amazing doctors here who can help with that. So please, just get it looked at. There's medicine available to prevent the madness.
Prevent the madness.
Yes.
I like that. Dr. Dilts, what do you wish people knew and understood about living with migraines?
Yeah, I think a lot of times it's an invisible illness. Just like you said, it's not just a headache. There is brain fog and kind of the stress of when the next attack is going to hit, and the nausea and all of those things that go with it too. And so especially a lot of kids can feel misunderstood with migraine. And so it is a big deal. But again, we have such good treatments. And so I think patients should feel really hopeful.
Victoria, for people watching who feel like I've tried everything, they feel despondent, like there's no hope, what do you say to them?
You know, I think now that we have a lot of newer migraine medications available, I try to tell patients, give us a chance, see a headache specialist, let us review the medications you've already tried and failed. And a lot of the times there's a lot of medications that we still have not been able, or that we have not been able to, treat for these patients yet and give them the opportunity to see some results. So.
And Dr. Ford, when you look to the future, say 5, 10, 15 years from now, how close do you think we are to curing migraines?
I think cure is going to be tough just because there are so many different triggers and so many different ways that they develop, but I think we are getting much, much more adept at treating and preventing them from happening as frequently.
Thank you so much for taking time out of your day to join us, Dr. Ford. Victoria, Dr. Dilts, Jennifer, thank you. And thank you to our viewers for joining the conversation and sharing your comments and questions with us. We'll see you right back here tomorrow morning.
The COVID pandemic affected all of us. New research shows its impact on the brain may go beyond infection. I'm Jessica Lovell on the next Open Mics with Dr. Stites. We explain the study that found signs of accelerated brain aging, even if you never tested positive. Wednesday at 8.